In my hands, this is a deadly weapon. I got him back. Welcome to Gut 4. Hey, get up. All right, colon cancer. We've already talked about cancer in general. You already know the 4 principles of oncogenesis. You understand oncogenes, tumor suppressor genes. The basic pathology of colon cancer really is the result of activation of oncogenes. KRAS is the most popular one. And loss of tumor suppressor genes. P53 is very popular. In addition, many colon cancers start with the loss of a tumor suppressor gene called adenopolyposis coli. The little picture on the bottom of the slide of my kind of childhood favorite TV show is also a reminder to mention the concept of driver versus passenger mutations in the setting of cancer. Any cancer will have oodles and oodles of mutations, but only a small percentage of those are what we call driver mutations. And that means mutations that create changes to proteins that drive the process of oncogenesis. So why do people get this very common cancer? Well, one reason is as we age, we sustain more genetic mutations. Also, as we age, we eat more garbage. And colon cancer is inextricably linked to our diets. In fact, back in 2015, the International Agency for Research on Cancer formally came out and said, look, red meat, especially processed meat, so think about your Oscar Mayer salami wiener, type stuff, is a class 1 carcinogen. There is enough evidence to show it damages DNA. And that was front page headlines for a long time. I think it was even in Cosmo. But you might wonder, how? How does red meat and processed meats damage DNA? Well, there's a lot of mechanisms, but they all seem to point to 3 major contributors. Nitrates, used to preserve or cure meat, and then the production of heterocyclic amines and polycyclic aromatic hydrocarbons. Both are produced through the way we cook these meats. So colon cancer is so common. How would you as a primary care nurse know who's got it and who doesn't in your clinical setting? The first thing I want to tell you is early colon cancer, much like pancreatic cancer, is often without any outward symptoms. This is why you primary care nurses will be urging patients to do fecal occult blood testing as a screening tool to look for colon cancer. It's so widespread in the population that early detection not only saves lives, it saves money. When colon cancer does start producing symptoms, bleeding into the gut is the most common symptom that it produces. Bleeding in the gut that's at the distal portion of the colon often produces hematochezia because the blood will be frank, red, and it hasn't had time to break down and actually mix with the stool yet. Bleeding in the proximal aspect of the colon, closer to the cecum, gives the blood time to break down, mix with the stool, and melena is the more common clinical result. A growing colon cancer in a patient's colon will produce polyps initially. So when patients have colonoscopies and polyps are found, they're often snared by the colonoscope and taken out, under the assumption that those polyps are potentially precancerous lesions. Does it guarantee they'd go on to become cancerous? No. And sometimes they are at the time they're pulled out. But even if they're not, benign polyps are snared too because the benefits outweigh the risks. There's only a few take-home ideas represented by this picture here. The first take-home idea is, as a colon cancer increases in stage, from stage 0 to stage 4, the larger mass it gets. In fact, the difference between stage 3 and stage 4 is the presence of metastasis. In stage 3, just as we said way back when we were talking about cancer, you still have a limited local mass. Stage 4, spread throughout the body. The other thing I'll point out is that the most common place for colon cancers to metastasize is the liver. And that probably makes anatomical sense, since you've got all of the vasculature from the gut all shipped through to the liver for filtration purposes. Now, colon cancer is bad enough, but did you know that colon cancer can exist inside of a syndrome called Lynch syndrome? People with Lynch syndrome have germline mutations to a number of tumor suppressor genes. And the way this plays out is that they tend to get multiple cancers in their lives, and they get those cancers at younger than normal ages. I'll go one step further and I'll remind you that when you're working with patients and you're asking them perhaps about a cancer history, if you notice that they've had more than one cancer and or had cancer at an earlier age than your usual garden variety ages, 40s, 50s, 60s upward, might be worth asking them about family history and maybe genetic testing. Lynch syndrome's clinical manifestations in men and women amounts to cancer of the stomach and colon, but in women that can also then include cancer of the reproductive tract, specifically the uterus and the ovary. Colon cancer can also occur in the setting of a germline mutation to the APC gene that produces a clinical pathology called familial adenomatous polyposis. In this syndrome, patients get hundreds of polyps within their colon, starting at a very early age in life. This condition has an autosomal dominant inheritance pattern, and the polyps that are formed are throughout the entire colon. It's not uncommon for these patients to need a complete colectomy, removal of the colon, in their late teenage or early 20s. The bowel obstructions listed here are meant to add some vocabulary to everything you're learning. Adhesions are basically collections of collagen and connective tissue, usually occurring after an abdominal surgery or trauma. And those collections, those fibrous bands of collagen and whatnot, can actually cause bowel obstructions based on where in the bowel they occur. A strangulated hernia occurs when a portion of the bowel pushes out, say, through the umbilicus, and then the rectus abdominis squeezes down on it such that it deprives the portion of the bowel that's sticking out proper blood flow. Intussusception is the telescoping of one section of bowel up into another. Telescope! A vascular origin to bowel obstruction basically means that the loss of good blood flow to a section of the bowel impedes normal bowel peristalsis, and that lack of wave-like movement causes an obstruction. Cancer can be a form of physical obstruction to the bowel, though I will say some patients can have some pretty massive polyps and, surprisingly enough, normal bowel regularity. And then volvulus or megacolon is a situation whereby the bowel kind of twists or moves in such a way that it creates a physical obstruction, and this can swell up in the area proximal to the volvulus or megacolon and can become a very serious obstructive process. When I talked about esophageal varices, I said, hey, they're kind of the hemorrhoids of the esophagus. And I wasn't lying. They're distended veins. All hemorrhoids are distended veins. Hemorrhoids can be internal, they can be external, but because of the relative proximity to the surface, they're easy to traumatize, and when hemorrhoids get traumatized, they bleed. And this is a common source of anal rectal bleeding. You know, you hear a lot in the news about gluten and gluten sensitivity and the effects of gluten and who's dating gluten and where gluten went on vacation and all this kind of stuff. And I don't want to talk about that, but I do want to talk about a very serious medical response to gluten, and that is celiac disease. The very real sensitivity, hypersensitivity to gluten in the diet. Celiac disease, some people refer to it as gluten enteropathy. Some people refer to it as celiac sprue. That was actually the name that I learned about it under way back last millennium when I went to nursing school. So celiac disease is the true immune disorder, kind of where gluten triggers this inflammatory response. My daughter has a friend in school who was recently diagnosed with this, and when you read the clinical presentation here on the slide, it literally reads with basically all of the symptoms that my daughter's friend had. And it was quite severe. She had malabsorptive issues for a long time, vitamin deficiencies and things of that nature. The diagnostic workup for celiac disease really hinges upon finding specific antibodies to kind of the gluten product and to tissue within the gut. But really, ultimately, this disease is, at least with the patients that I've had, it's all about lifestyle and lifestyle changes. It's not easy, but at least with the patients that I've worked with that have been able to adopt a gluten-free lifestyle, the change to their quality of life is so beneficial that it becomes reinforcing and it helps them stick to a gluten-free diet. Okay, I would be remiss if I did a gut talk or an infectious disease talk and didn't include C. diff colitis. I didn't have it in my ID talk this year, so it's going into the gut talk. It's going to cap off the gut talk. C. diff colitis is, as the name implies, inflammation of the gut, specifically the colon, by way of the Clostridium difficile bacterium. We've learned about Clostridium perfringens. We've learned about Clostridium botulinum. Today we're talking about Clostridium difficile. Now, how does Clostridium difficile get into our bodies to begin with? Well, the truth is it really can't do much to those of us who have a nice, intact gut microbiota. For C. diff to get in, two things have to basically happen. More often than not, we have to take some antibiotics, usually for something else, and kill off some normal gut microbiota, kind of clear out some real estate. And then along that same time, we have to acquire the C. difficile bacteria and allow it to populate the gut. Even in that scenario, not everybody gets C. diff colitis. Only about half the people do. The other half become colonized with Clostridium difficile. and not necessarily symptomatic at all. They just have it in their bodies. Could they potentially pass it on later? Yes. Or they may never. Now, the other half of individuals may get acutely ill with C. diff colitis. In that population, there's two possible outcomes. Most people will recover from C. diff colitis, recover fully, and do fine afterwards. And by saying do fine, what I mean is they will not have recurrent C. diff colitis. However, in some individuals, C. diff is very, very challenging to eradicate. This is often in older adults, people who have to have exposure to other antibiotics, and they get re-exacerbations of C. diff colitis. The last thing I should mention about C. diff colitis is that the spores that are produced by C. diff cannot be removed through hand sanitizer. This is the one time where soap and water is the only thing that's going to do the trick. So wash your hands.